My name is Eric Rowland. I'm a medical oncologist and palliative care specialist at the Oregon Health and Science University. And today I'm going to be discussing the not so hidden burden of cancer cachexia and why it matters. These are my disclosures. So before we begin, I'd like to ask everyone just to reflect a little bit and think about the average patient with advanced GI cancer who comes to your clinic and ask how many of your patients living with advanced GI cancer present with weight loss at diagnosis. And I think many of you are picturing patients that you're seeing each and every day and thinking it's quite a few. Well, with those living with advanced GI cancer, it's over 50% present with more than 5% weight loss at diagnosis or during their actual treatment. Of course, the weight loss varies by primary cancer type, the tumor location, but GI cancer is associated with multiple poorly controlled symptoms that impact nutrition and weight, including nausea, pain, alternating diarrhea and constipation, and mucositis, just to name a few. And as we're trying to measure weight, ascites or third spacing of fluids can obscure our weight loss measurements, complicating factors further. So, what is cancer cachexia? I think that this is a topic that is not well discussed with patients and their caregivers. And I have lots of different patients that come to me in severe distress, concerned about the weight loss they're experiencing, but also their loss of appetite, their loss of muscle, and the profound fatigue that they're experiencing. And they all feel like it's their fault that they haven't been trying hard enough to get the calories they need. And so just introducing the term cancer cachexia is very important when you're taking care of patients. Most patients don't know what this term means, much less know how to spell it. And I introduced the definition of cancer cachexia as a hypermetabolic weight loss syndrome associated with cancer and its treatment. When patients hear about cachexia, they don't know what it is. Caregivers don't know really what it is. And then when clinicians hear the word cachexia, this is what they're envisioning. They're envisioning a patient who is severely emaciated with severe malnutrition. And although that is true, this is part of cachexia. This is at the later end or the later stages of cachexia. While those of us who have been studying and dedicated to this field think about cachexia quite differently. We think of cachexia on a spectrum, with kind of the severe emaciated cachexia being what we call refractory cachexia, where patients have weight loss, appetite loss. They're having a limited response to the anti-neoplastic therapy. They're in a pro-catabolic state with a low functional performance and limited prognosis. In contrast, if we march this up a little bit, we see that cachexia, as defined by an international consensus criteria in 2011, led by the late Ken Fearon and colleagues. Cachexia, under this working definition, was defined as weight loss greater than 5% or a BMI less than 20 and a weight loss greater than 2%, or sarcopenia or low muscle mass with the weight loss of 2%. And then here we see the reduced food intake and evidence of systemic inflammation. But the piece even earlier than that is the pre-cachexia phase. And I have to say that most people are unaware of this phase. This is where people are starting to experience their weight loss, losing their appetite, and experiencing metabolic changes. And what I'd like our community at large is to start to recognize these early changes where interventions are more likely to have a more profound impact. I'll note that this approach to defining cancer cachexia as defined by Fearon and colleagues in 2011 only had the arrow at the bottom of the screen going in one direction, all the way to refractory cachexia. But we now have evidence to demonstrate that if even in the refractory cachexia state, we do have interventions that can reverse these changes. And we need to really focus on incorporating a multidisciplinary management to the cachexia syndrome. Now, what causes cancer cachexia? Well, the answer is a little bit of everything. What's really driving this is the tumor and its growth. The tumor secretes cytokines, including growth differentiation factor 15, which is a notable one given some ongoing clinical trials. It impacts multiple organs, including the liver, where we see acute phase proteins. We have increased toxicity, decreased drug clearance. It's affecting the brain and the brainstem with decreased energy intake, the experience of loss of appetite, this anorexia, um, and neuroinflammation. And then at the muscles, we're seeing decreased muscle strength, decreased mass, also called sarcopenia, an inability for the muscle to regenerate, decreased protein synthesis, while we're also seeing increased protein degradation. And as Dr. Kadakia and colleagues described in the ASCO Ed book in 2023, we also see that this cachexia affects the immune system and inflammation, with well-documented increases in tumor necrosis factor and interleukin 6, IL-1, among others. And then this is affecting the gut, leading to gut dysfunction, malabsorption, even increased risk of diabetes, dysbiosis, and inflammation. And then we're seeing changes in brown adipose tissue, white adipose tissue, and even in bone mass. So this syndrome is highly complicated with lots of organ crosstalk and incredible opportunities for understanding these relationships and targeting these signals to improve the response to our interventions, but incredibly complicated. So as an oncologist and a palliative care specialist, I am very focused on understanding the underlying cancer, how to define it. We're focusing our research on biomarkers of response. We want to make sure that the cancer is being well controlled. And in my training, I was taught the best way to control cancer cachexia is to control the underlying cancer itself. That is true. And we need effective cancer treatments that are able to control the cancer while also optimizing the quality of their life. And so we think a lot about the cancer treatment, and we measure the tumor, and we discuss tumor responses. But at the same time, we need to be very clear that what are the person-centered factors here? And that includes the weight and appetite loss, as well as the loss of function and activity, which really is a measure of a loss of independence. And furthermore, we're seeing changes in the skeletal muscle, as we described, the symptoms of patients, their quality of life being impacted, obviously an inability to keep up with their nutrition and their dietary intake, which of course can be socially isolating and not being able to be involved at mealtime. Survival is also a very person-focused endpoint, so I put it on both sides of this coin. And then we see an increase in healthcare utilization in patients experiencing cancer cachexia, and more time in and out of the hospital, the emergency department, or the infusion center. So it's incredibly important that we think about both sides of this coin rather than one side or the other. And many people ask me, well, what can we do for cachexia if we should just focus on the cancer and its treatment? And I think that's a really limited approach. In the same way that we take care of patients living with cancer and experiencing pain, we should also think about how we address cancer cachexia. So for example, if someone has poorly controlled cancer pain, we don't ignore the pain. We treat the pain at the same time that we're treating their cancer. The same would be true for nausea and vomiting, where evidence has demonstrated that if we can control someone's nausea and vomiting, we can also improve their ability to tolerate cancer treatment, getting their treatment on time, without delays or dose modifications. So in the same way, is there any way for us to optimize the care of patients experiencing cancer cachexia, looking beyond the cancer itself and trying to optimize patient-centered factors? And I mentioned this previously, but cachexia does have an impact on cancer treatment. And so when I talk to my medical oncology colleagues, I often hear, well, what does this matter? Well, it matters because we desperately want to get our effective anti-neoplastic therapies into our patients on time without dose reductions. And unfortunately, cachexia as a hallmark is linked to impaired delivery of anti-neoplastic therapy with more dose reductions, treatment discontinuations, and an inability to complete the planned regimens. My colleagues and I have published a systematic review on over 15,000 patients showing that cachexia-related findings included these dose reductions, treatment discontinuation, and increased treatment-related toxicity with over a 2.5 higher likelihood of having a dose reduction or discontinuation. So this matters not just from the patient experience, the caregiver experience, but also our ability to control their cancer at large. So myself and others were interested in how cachexia affects prognosis. And we did a large claims retrospective analysis comparing patients with documented cachexia as defined by the Fearon criteria, as well as capturing when the actual diagnostic code was used in the electronic medical record by medical oncologists. And what we observed was a very interesting trend. So in this large claims database presented at the annual meeting at ASCO in 2024, we see that the patients with the best prognosis are those without cachexia. Next, those with an observed or measured cachexia as defined by weight loss and without having any metastases. You'll see a hazard ratio of 2.32 there. Then patients without cachexia but do have stage 4 or metastatic disease with a hazard ratio of 3.12. And then we see this cachexia observed with metastasis, and you see the impact there with a hazard ratio of 6.42. Then we get to this interesting use of the diagnostic code of cancer cachexia in the medical record. And you'll see when oncologists use that diagnostic code, the prognosis is horrible. That is actually demonstrating without METs a hazard ratio of nearly 15 and with METs a hazard ratio of 20, indicating that when doctors are documenting that diagnostic code in the US healthcare system, they're really trying to say this is end-of-life care, which again demonstrates the notion that cancer cachexia is an end-stage event rather than seeing the early stages and trying to intervene earlier. So the patient experience, I've got to tell you, when I talk to patients about cachexia, they're talking about so many losses and grieving those losses. They're seeing their body change in front of them. And this brings up a lot of issues around a physical manifestation that their cachexia is a sign of their cancer not responding to treatment. They're feeling tired. They have this weakness despite trying to do more and really becoming increasingly dependent on others. So there's this loss of independence. So this impacts the patient beyond just the physical manifestations, but really is a threat to their self and their independence. And another reason why we really need to focus on ways to support patients and their loved ones in this tough situation. So my approach to this is just to team up as best as I can with as many folks from across the institution as possible. And so here we published this in 2016 as just a model of, in an ideal situation, what we would be doing. And the first thing would be, of course, to identify that cancer cachexia exists in these early phases, performing our physical assessments, including physical activity, capturing early reports of patient reported quality of life and their symptoms, ensuring that we are treating any poorly controlled symptoms that may be related to a decrease in nutritional intake, such as nausea or pain. I would encourage early integration of our palliative care colleagues based on our international guidelines and multiple phase 3 clinical trials showing that quality of life improves with early integration of palliative care. At the same time, we're looking at ways to improve or maintain physical function through physical exercise, rehabilitation, and trying to identify those experts in your institution or community who understand this unique situation and are able to engage. And so this would include physical therapy, occupational therapy. We also have colleagues focused on exercise oncology interventions. At the same time, we're reaching out to our registered dietitians, making sure that they're available and then can continue to follow up with patients. One concern that I have across the US healthcare system is the staffing of registered dietitians, ensuring that there is enough available so that there's not a one-time single consultation, but ongoing visits to address the changing needs of patients and their caregivers around nutrition. And then, of course, as we advocate for more education and resources and caregiver support, we also need to prioritize clinical trials in this space where supportive care interventions have the same importance as our cancer-directed therapy trials. And so funding and clinical trials in this space, as well as engagement in our international communities focused on cancer cachexia, remains critical. So thank you all for this opportunity to talk to you about the not so hidden burden of cancer cachexia. Appreciate your attention.